All right, hey everyone. My name is Shrihan. Thank you so much for joining us this evening. This is Dr. Winkler. We're going to be talking to him today. Do a Q&A and then do a case study near the end of the session as well. For everyone new to PhysiLink, this is our website right here. The goal with PhysiLink, the overarching goal of PhysiLink is to create a growing network for pre-med students. And so each month we choose a physician and a resident of the month. And so there's a ongoing Q&A that you can ask questions throughout the month, and at the end of the month, Dr. Winkler answers these questions. And then throughout the month, we also do a case study and a webinar. And you'd also go to previous physicians to look at this database, and here you can see the recording of the last webinar as well as doctor details, and look at the questions and all the answers as well. And just make sure to join the newsletter as well right here to see or to get updates of our new physicians and new residents each month. All right. Well, we can get started. Dr. Winkler, if you want to just introduce yourself, tell me a little bit about yourself. I'll share your background, your education.
Yep. So I'm one of the emergency medicine physicians at Prisma. I also work at MUSC here at most of the hospitals here in Columbia and the Midlands. I completed residency here at the USC program at Richland. Originally went to undergrad down in Florida at USF, did med school at LECOM, the DO school in Bradenton, Florida. And then I joined the Navy. I did an initial internship and a transitional year internship in the Navy. And then I went to flight surgery pathway, did some flight aerospace medicine training in the Navy, and then was a flight surgeon for 4 years. And then after that, I got out of the Navy, and then I completed pretty much my payback for them for essentially paying for med school. And then I went and completed an emergency medicine residency, and then I stayed here afterwards.
All right, and approximately how long have you been practicing so far?
Practicing medicine, I guess total be 12 years.
Okay. Well, thank you so much for being here. We can get started with the questions. Can you talk a little bit about the difference between a DO and an MD and sort of why you chose the DO path?
So a DO is just kind of a different type of, degree. I guess the big difference is DOs traditionally kind of treat the patient as a whole, a little bit more homeopathic. Traditionally, maybe not so much anymore. Allopathic is MDs, and they're kind of more based off treating the actual disease process rather than the patient as a whole themselves. And DOs also do some like manipulation. They call it osteopathic manipulation. I would say probably 90% of us don't keep up with it after you graduate. But the person that started chiropractic medicine actually failed out of the first DO school and then started chiropractic medicine. The reason why I chose DO is because my parents lived in Bradenton where the school was. It was the only school I applied to. But a good thing about the school that I went to down in LECOM in Florida for me is there's no like true lectures. It was all what they call problem-based learning. So I was only in school probably 2 hours a day. So that was kind of more beneficial for me. So I don't take a whole lot away from lectures and things like that. I'm kind of more of a self-taught person. So it's all about reading on your own and kind of taking things at your own pace.
Do you think the style of learning and education is different between DO and MD?
No, I don't. Not necessarily. I think that it's med school to med school dependent, and there's different styles of teaching now, not just the traditional lecture based, and it depends on what med school you go to. There's different pathways at all schools.
Okay. All right, now a little bit more about emergency medicine. Can you explain sort of what your specialty does in those typical cases that you face and sort of a caseload that you face each day?
Yeah, so emergency medicine, we generally work in emergency departments, not always, but you kind of just see whatever comes through the door. So you have to be prepared for anything along the lines of traumas, any strokes, cardiac stuff, pediatric stuff, dermatology, neurology, any specialty. You pretty much have to kind of have a pretty solid background because you deal with patients in their first few minutes in the hospital coming in for a wide range of medical problems, and you kind of like identify, stabilize the patient, diagnose whatever's going on, and then you kind of reach out to, a specialty that might be needed, or admit them to the hospital, or treat whatever process is going on, and potentially discharge. Um, and that's kind of the basis, I guess, behind emergency medicine. The nice thing about emergency medicine is that it's every day is different. You never know what's going to come through that
Yeah.
door, from 1 minute to the next. So most time, two shifts are never the same.
Yeah. And can you talk a little bit more about that multi-specialty training and how you get exposed to all the different specialties during a residency?
So in residency, I mean, you do lots of rotations where 1 month you go and you kind of work on one service, another month you go somewhere else. So you get some background with OBGYN, you get some background with cardiology, neurology, orthopedics, all those different things. But on a day-to-day basis in residency, you're seeing it all. So you're seeing a chest pain, you're seeing a potential stroke, you're seeing a pregnant female, you're seeing kids. So you're seeing stuff every day. It's
Mhm.
just that repetition of those disease processes that you kind of continue to, you know, embrace and kind of expand upon, and kind of just, continue to recognize what you're looking for. And so we don't know, an ER doctor doesn't have as much training as a cardiologist,
Yeah.
but we know, you know, we have a lot of different things that we look out for. So we were looking for
Mhm.
a heart attack. We're looking for, different, arrhythmias. And so we kind of have an idea of the really dangerous things that we're going to look out for. And if we need more, then we consult cardiology.
Okay. Yeah, so sort of along with that, when you're sort of involved in all the specialties, do you also get to collaborate with all the physicians and specialties throughout the hospital?
You generally do. Sometimes you'll
Mhm.
reach out and discuss them. We call it consult. You'll consult a specialist, asking for their opinion or their guidance on something. If you kind of need a little help with something, sometimes you just admit them to the hospital, and then the specialists kind of take over at that point. So it kind of depends on the situation.
Got it. And then could you talk a little bit about the shift work and the hours for emergency medicine? I know a lot of people say it could be a little hectic, a little overwhelming. Can you talk about how you schedule your shifts each week and sort of the hour requirements?
Mhm. So every job's different. Some jobs there's multiple docs working at a time. Some places, the smaller emergency departments, there's only one doctor at a time, and so it kind of depends on the ER itself. So sometimes you'll work anywhere between 7 to 8 hour shifts to 12 hour shifts, and then some smaller places you'll work 24 or 48 hour shifts. But a lot of the times, obviously, you're sleeping there at those places. They're not as busy. So it all kind of depends on the type of hospital you're in. If you're at what is called a critical access hospital, so a really small hospital in the middle of nowhere, sometimes you're working those long 24-hour shifts, and you sleep there, and maybe you'll see five, six patients, eight patients in a 24-hour period. And in busier hospitals, generally people will work shorter shifts just because it's more demanding on your body and brain. So it all depends on the kind of the facility you work at. And as far as like when that also kind of depends on your job. Most people will have like a varying set of shifts. So I'll work like a morning shift, an evening shift, and then I'll maybe a couple night shifts or something like that. And you'll get a couple days off. And then it kind of depends on your contract, wherever you work. Do you work, 150 hours a month? Do you work 120 hours a month? And they kind of just piece that up with your shifts.
Okay, but you think it is pretty flexible how you can choose your hours when you want to work?
Yeah. Yeah, that's the nice thing about emergency medicine is that, while you're at work and you're busy, and a lot
Mhm.
of times it's a busy, day, but when you leave, you don't have patients that are, calling you, or you don't have other things going on, because you leave work and you leave it at work. You don't get calls, and you're not on call generally in emergency medicine. So when you're done with work, you're done with it. So another nice thing is that you can kind of, if you want to go somewhere for a week once a month, a lot
Mhm.
of times you can do that vacation every single month, because you can shift your schedule around the way you want it a lot of places. So it kind of depends on where you work, obviously. But if I can at Prisma, I can actually request 9 days off every single month, so I could do something for nine days every month that I wanted to do.
Yeah, that's really good. And sort of going off of that, so you don't really keep long-term relationships with your patients, right? They're sort of just in and out, and you don't take them home. Yeah.
Correct. Yep.
And then moving on, so what are some common challenges or problems you face in emergency medicine, working with patients, cases, anything?
I would say that the biggest challenge we have now in emergency medicine is that we're kind of society's safety net. A lot of people have trouble with access to healthcare, so they come to the ER. There's something called EMTALA, which is a federal law that means we have to evaluate and treat um, any patient that comes through the door of an emergency department for any potential emergency. So, you know, homeless people that don't have a primary doctor or any money, they frequent the emergency departments. They come up with different complaints. So, I mean, there's several people that we see almost daily in our ERs. We know them by name. We know what they're coming in for, but we have to evaluate them every single time. And they kind of use it as as like a shelter. And other people that have a lot of financial issues. They continue to come to the ER and don't see other doctors because they don't have any financial backing, so or insurance. So that's probably the one of the biggest downfalls of it at this point is our society is kind of leaning on the emergency departments more and more.
Yeah, so sort of going off of that financial backing, how does the insurance work with the ED? Um, do patients pay for it? Does it work after or
So we can't turn them away, if they have no insurance or no money. So still have to see them. But a lot of times, we in the ER is another nice thing is I don't have to deal with or worry about can a patient pay for this. Can this be covered by insurance because it's emergent. Everything in the ER is considered emergent. So I just order what I think is necessary for a patient, and then the billing people all kind of take care of the stuff in the background for me.
got it? And so I shadowed emergency medicine a few months ago, and so a lot of the patients were saying that their physicians that they referred to in the hospital when they didn't have space, they just send them down to the ED. Do you still face that problem in Prisma as well?
Oh yeah, that's a big deal. Yep. People. I mean, we're the safety net, but we're also the dumping ground for everybody. So, but
Yeah.
it's just one of the every specialty has a downside, and that's one of the downsides for emergency medicine. So no specialty is perfect, but that's one of the things you deal with.
Yeah, well, thank you so much. And just in case anyone has any other questions, feel free to drop in the chat. I can sort of include them in here or just cover them at the end. And then a little bit about your background as well. You mentioned being a flight surgeon. Can you talk a little bit about your experience as that and sort of how long you worked as a flight surgeon?
Sure. So when I got accepted to medical school, there's a scholarship program called the Health Professional Scholarship Program, so HPSP, and they have that through the Navy, the Air Force, and the Army. Each has one. So essentially, you get accepted to med school. You find a physician or a officer recruiter for whatever branch you're interested in, and they usually just straight up offer you the scholarship. So what it is, if you do it before you start school, is it's 1 year to 1 year. So they pay for 4 years of med school. You owe them 4 years active duty, but out of training. So not during residency um, or like an internship.
Right.
So what I did is I did a 1 year internship active in the Navy. I was in Portsmouth, Virginia, at the largest naval hospital in the world. I did a transitional year, and then I went from there. You can either go straight through residency. I could have went to dive medicine, became a dive medical officer, or a flight surgeon, or what they call a general medical officer. So I could have went on a ship and been a doctor on a ship or something along those lines. But I chose flight medicine. So what I did is I went from there. I went to Pensacola for like 8 or 9 months. I did, I think, 2 or 3 months of training in fixed wing aircraft. So planes, 2-seat planes that fully aerobatic, go upside down, do all the things, have ejection seats. And they teach us how to fly. We did I think, a 8-week course with all the Navy pilots. The initial course that they do on the ground. So we learn about engines, aerodynamics, navigation, all those things. And then we did a 8-week course to learning how to fly helicopters. And they're not, it's not the same course the Navy pilots go through as far as like, they take 2 or 3 years to learn how to fly airplanes. But we did 8 weeks in helicopters, 8 weeks or so in fixed wing. And then after that, we did another couple months of aerospace medicine training. And then following completion of that course, you were selected to a certain type of squadron. And it didn't really matter. They just put people wherever. And you could go into helicopter squadron in Florida. You could go to a helicopter squadron in Japan, a jet squadron somewhere. they put people all over the country. So you go somewhere generally for 1 to 3 years, depending on the type of job it is. If that's, job deploys, you may deploy. If that job is a training squadron, you may stay there that whole time. And then you're essentially primary care. So you're primary doc for that squadron or that unit that you go with. And then you're required to actually fly. At least you were required to fly 4 hours a month. And if you met that requirement, you actually got flight pay as well. So usually I would work, just Monday through Friday. I go into clinic 2 to 3 days a week. See clinic between 8 to 3 p.m., 4 p.m. And then 2 days a week, I would have 1 or 2 days a week, I'd have squadron time. So I'd fly or hang out the squadron. Um, and then, if the squadron deployed during that time, then I went with them. So I spent 2 years in Whidbey Island, Washington, with a jet squadron out there. So I got about 150 to 200 hours in fighter jets in the backseat, two-seater jets. And then I went to Jacksonville, Florida, and Mayport. And then I was a flight surgeon there in a helicopter squadron for 2 more years. And so
So
because I did the 4 years as a flight surgeon, that wasn't during training, I paid my time back for the military. And then I was essentially released from any obligation. And then I got into a civilian residency.
got it. So sort of all the training combined, approximately how long was that with learning how to fly the airplanes, the helicopters, the specialized training?
That was about not my internship, but just the flight surgeon training was probably about 8 months or so.
Okay. And so can you talk a little bit more about the day-to-day life of a flight surgeon? I know you were saying the shifts that you have, but also what procedures do you do? What do you actually do in the airplane?
As a flight surgeon,
Hmm.
you're just flying. So when you're in an airplane, you're just flying. You're not actually doing surgery in the aircraft. That's just kind of like
Yeah.
that's just the name. But you're doing primary care. So you're doing flight physicals in clinic. You're seeing sick call, seeing people for injuries, twisted knees, coughs, colds, abdominal pain, vomiting, things like that in the sick call. They're generally healthy, active duty military
Mhm.
personnel. Generally not seeing civilians. You're not seeing family, things like that. Just the active duty people.
Yeah. And sort of following up on that, how do you think your career as a flight surgeon played a role in your development treating treating patients in civilian EDs?
I don't think the medicine was super tough, to be honest with you. I think it would help. It helped me become a physician, a better physician overall, because you kind of live, eat, and travel with your patients for 2 years. So your patients kind of become your friends and your family. At each squadron, I probably had 200 to 300 patients, and that's it. Most primary care docs have several thousand. So I travel with my patients, and I kind of got to know my patients, just like they're, your buddies. So I think that kind of changed the way I talk to patients and dealt with patients, long term. But as far as emergency medicine, I don't think it had a whole lot of correlation.
Got it. And then can you talk a little bit about your most surprising or unexpected aspects working either as a flight surgeon or working in specialty emergency medicine as well?
Well, the most surprising thing to me, I think, looking back as a flight surgeon, was probably the adventure. I think I had a great time traveling around the world, doing things that most people never get to do, especially that people that are in medicine. I've flying in jets, breaking the sound barrier, going across the world, doing all sorts of cool stuff, hanging from helicopters, flying around mountains from a rope. I got to do a lot of really, really neat things. My wife got to travel around the world too, places that you'd never go. It was more of an adventure, which if I could go back and do it again, I totally would go back, and do it again. And it was more because I'm going to be practicing emergency medicine for what, 20, 30 years or so. I only got to do that for a few years, and I think it was worth it to have those experiences. Um, and as far as emergency medicine, like my biggest surprise, I think is how tired you can be after shifts. A lot of people have jobs. A lot of other specialties. You have jobs where you take your time, think about a patient, look at all the objective information that you have in front of yourself. But in the emergency department, a lot of times you don't have time to think and you don't have time to sit and breathe and eat and go to the bathroom. You're just going from patient to patient for hours. And it can be tiring. It's rewarding, but at the same time, it can be a tiring job.
Yeah, for sure, definitely. Um, going off of that, sort of going back and forth in patients, making quick decisions, are there any skills you think you've learned working specifically in the ED or as a flight surgeon that you think are really beneficial?
Um, Time management. I think time management is a big one. Making really fast decisions with limited information is probably something that you kind of learn and develop through residency in emergency medicine.
Yeah, and then going along with that, do you have any tips for managing stress? ED is definitely a high stress environment as well as definitely being a flight surgeon. What are some things that you do in your own personal time and free time to handle that?
Leave it at work. Try not to take it home with you. Yeah, try not to think about those things after you leave work. You gotta leave it at the door and go home and be with your family or have fun doing your whatever hobbies or activities that you have.
Yeah, sure. I think it definitely helps that ED is case by case, so you don't take your patients home as well.
Yeah, that was a big thing for me. Not getting calls in the middle of the night. Once you go home, you're off. No one bothers you. No one calls you to ask you for something. No one calls you to ask you a question. And once you leave, you're done, which is kind of nice. It's a stressful job while you're there, but at the same time, when you're home or when you're off work, you're truly off.
Do you have any overtime work required as well, or not overtime, on call work at all, or no?
No, no on call
Oh,
stuff. Some people have like separate jobs,
mhm.
like within groups. The emergency medicine group at in Prisma here in Columbia is real big. So, some people will have medical directors, so they're in charge of the emergency department. So they have to go to meetings. Some people will be on different committees. We have like sepsis committees, stroke committees, chest pain committees. We have toxicologists that work for the poison center. We have people that work with the med school. So people have different jobs. They elected to do those, but generally you don't unless you want to do something else.
Have you thought about joining any committees, or are you part of a committee right now?
I'm not a part of a committee right now. I have been part of committees several times in the past. I'm actually getting ready to leave the area. We're moving to another state, so I'm not involved in anything anymore.
Yeah. Can you talk a little bit about your experience of the committee and sort of what it involves? Um,
So, yeah, so like let's see, I was the chair of a of a committee several years ago, and it was you reviewed cases. Um, there it depends on what the committee is. I mean, a lot of committees, like let's say if you're on the sepsis committee, you review cases of sepsis and potential what we call misses. So like things weren't ordered that or medications weren't given, antibiotics weren't given in a timely manner for infections. Stroke committees, people that want to review cases through the hospital and make sure that the appropriate treatment is being given to patients. Um, if there's anything that's brought up, any concerns for other patients, um, you review those things. People are on there's a pharmacy committees where you review medications and what medications that we're going to have on formulary, meaning the hospital wants to pay for, and what medications we don't. um, so I mean, there's all sorts of different committees, and you can involve yourself medical directors, so they're in charge of like the overall direction of how the ER is run and things like that. So there's lots of things you can do if you're interested in those things.
yeah, so as being part of committee, do you also get to make any policy changes as well, or is it primarily just?
Sometimes, so it depends.
Mhm.
It depends on the committee, and it depends on what you're doing. But as far as policy changes, a lot of times those will come up from from higher up. So like medical director, there'll be like a hospital executive committee, and things like that. And those are more the higher level committees are the more the committees that will actually make true policy changes.
Got it. Okay, we can now move on to a few questions that were asked in the chat. One of the questions was, if you worked with residents, have you noticed any differences between your DO or MD residents? And also, do you feel you have any differences in your perspective on emergency healthcare from your counterparts because of your DO background?
I think generally it's hard to truly tell at this point. After residency, if you do an American residency, like a good residency program, MDs and DOs are interchangeable. I don't think there's a true difference at all. And as far as like med school, if you do a med school in the country, MD or DO, that no one really, once you get to where you're practicing medicine, no one really cares about where you practice or where you went to med school. It's really all about where you do residency. The residency is way more important, in my opinion, than a medical school. Everyone passes the same steps and stuff like that in med school. So I think if you get through med school, it's all the same. But the residency is truly where you kind of learn to become a physician. And I think that's more important than if you went to a DO or MD med school. Um, for me, going to the school that I did, where we had problem-based learning, where I didn't have 8 hours of lectures a day, was big for me because that actually allowed me to prepare better for my boards, step 1, 2, and 3, which you take in med school. So it's kind of what you feel would work better for you as far as med schools, but in my opinion, it's more important about residency, not med school.
Got it. Okay. And then the next question, someone asked, what do you wish you'd done differently during your time as an undergraduate student?
I wish that I probably would have studied harder in the beginning, my first year or so. I wasn't sure I wanted to go into medicine my first year of undergrad. I would have studied harder. I think that a big part of it is just kind of staying focused. If you truly want to go into medicine, just stay focused. I think that, things are obviously a lot more competitive now than they were 20 years ago, as far as, everyone's trying to do extracurricular activities and get the best grades and all those things. But I think staying focused and then getting involved with medicine early is probably the most important thing.
Yeah, and then going off of that, especially as an undergrad student, can be stressful going through the path of med school. Could you share your thoughts on any strategies you use to manage your time or any important skills that you think would be important for success?
In undergrad,
Yeah, in undergrad, med school, just as you're progressing throughout your medical career.
I think that shadowing, I think, is a big thing. Getting experience, whether you're um, like scribing or getting, working, volunteering, by getting into a hospital, getting experience, meeting some doctors. If you have a med school that you are interested in, maybe meeting some people that are involved or has something to do with that med school or some of the residency programs, and trying to get involved and kind of just get known. I think people that can get recognized, um, from in med school, and then also for residency, once you're in med school trying to get into residency, I think being able to be recognized and remembered by some of those people that are making those decisions is probably a great way to kind of get to where you want to go.
Got it. The next question is a little bit more about your experience in emergency medicine as well. How do the cases and patient volumes differ between the rural and urban emergency departments?
um, well, it kind of depends on the patient population. So if your patient population is like here, let's say here in Colombia, we have a super high percentage of like HIV patients compared to the rest of the country. We have a ton of sickle cell patients compared to the rest of the country. So, you go other places like, I've worked in like South Dakota. You don't see any of that at all, ever. So, you'll see things from, Native American reservations. You'll see a lot of, alcohol out there. I was in West Virginia. In West Virginia, you see a lot of like COPD, lung issues from miners, coal miners, things like that. So it kind of depends on the population. If you're in a large city, you'll probably see more trauma, penetrating trauma, car accidents, things like that. If you're kind of in a more rural area, you'll see stuff that's maybe associated more with so like agriculture and things like that. So it depends on the population. It kind of depends on what the population is doing wherever you are.
Yeah, so you think the typical cases you see sort of depend by the geographic area, which cities you go to, and sort of which area of the country you're in?
Exactly. And what the people do. I mean, some places there's more different types of drugs are more prevalent. Some people places there's more, people that smoke cigarettes or whatever. So yeah, it's kind of dependent on where you are and the population there.
Got it. And going back to the issues you were saying that most EDs face, do you think that also changes depending on which hospital you're working at and which region you're working at?
Absolutely. So, as far as like, if it's a lower income area, less, we call a payer mix. So if it's a poor payer mix, meaning there's a lot less, insured patients, things like that. You'll have a lot more people coming in. kind of looking for primary care, medicine refills, things like that in the emergency department. Um, you know, so it kind of depends. That changes things. If you have like a very affluent, um, kind of population there, that a lot of times people will be expecting more. They want you to kind of wait on them hand and foot. Bring them a blanket, bring me a sandwich. Where Why have I been here for 30 minutes already? So it depends on the population, and you know.
Yeah, definitely. All right, moving on to the next question. One of the students asked, when you're going into the military as a position, why did you choose the Navy over the other branches?
I had family in the Navy, so I chose the
Mhm.
Navy for that reason. Um, you know, Navy always has bases near water, so if you like water, it's a good place. It's a good one to pick. I would say the Army has a lot more opportunities, has a lot more different places you can go and work and do residency in. The Navy only has really three big hospitals that have residency programs. There was one in San Diego, one in Portsmouth, Virginia, and then one in Bethesda, Maryland. There's a few other smaller hospitals that'll have like your family practice, but that's it. Um, Air Force. The nice thing about Air Force is they always have the nicest spaces. So wherever you go in the Air Force, you'll have the nicest gyms and stores and restaurants on bases. And a lot of the other uh, branches really don't have what the Air Force has.
Yeah, were you considering any other branches besides the Navy, or were you pretty dead set on the
No,
Navy?
I was pretty much set on the Navy. Several of my other friends, though, they're in other branches. So I've and then when we traveled around their world a lot, most of the time I was actually at Air Force bases.
Cool. All right, I guess moving on to the next question, one of the students asked, how do you advocate for your patients, and how can that be challenging sometimes?
Well, you do what you can for everybody. Depends on what they're there for. Sometimes they don't advocate for themselves, and that's hard. You know,
Yeah.
they're like patients will come in and let's say they have a really bad dental issue, and they just want narcotic pain medicine. Then you send them to a dentist, and they just ask the dentist for more narcotic pain medicine. They don't want their tooth pulled or fixed or whatever. So it's hard to advocate for people sometimes. You see them for alcohol withdrawals or drug withdrawals or whatever, and then you try to help them and give them all the resources. Do what you can, and then they just leave the hospital and they go out and they start drinking again or using again or whatever. So you do what you can, with what's appropriate. Um, but sometimes patients are hard to to deal with because you want to do everything you can for them and they don't have to help themselves. They don't go to the referrals, they don't go to the appointments you make for them. So emergency medicine can be hard for that reason. You're trying to help these. A lot of the people are homeless, and you try to help them do what you can, and they don't have to help themselves.
I think that is definitely a big issue. Also the opioid crisis is also a pretty big issue in South Carolina as well. Can you talk a little bit about that and how you see that in your day to day?
Yeah, I mean, we see a lot of chronic pain patients, patients that see pain management doctors. They get lots of narcotic pain medicine, on monthly prescriptions, and they continue to take them more than they should and run out, and they come see us. You know, the nice thing is that we kind of have a rule that we don't give them more than 3 days worth of pain medicine from the emergency department. So that kind of forces our hand to say, hey, I can only give you a couple tabs, or I'm not going to give you anything, or so I'm not having people ask me for 2 months of or a month of narcotic pain medicine. Um, which has kind of helped. And we also have a electronic system where we can actually look up and see where they get their narcotic prescriptions, and they anywhere they pick up a prescription, it shows us who prescribed it, how much they got, and when they got it. So that's kind of been a nice thing. We kind of help guide us whether they should be getting something or not. So that way they're not shopping from hospital to hospital, picking up different prescriptions.
Yeah, so you can kind of track the patients and their medication usage.
Exactly.
And then going off of that, how do you differentiate between patients that genuinely have pain or patients that are solely drug seekers and looking for medications?
It's experience based. I would say kind of how they act and how they talk. If they're asking for specific narcotics by name, we kind of know which ones they're asking for and looking for. You could also tell if someone's in pain by their vital signs. If their blood pressure is high, if their heart rate's up, um, you know, those are signs of pain, true pain. People, someone just sit there looking at their phone, they look up at their phone after they're playing, while they're playing Candy Crush and tell me they have 10 out of 10
Yeah.
abdominal pain. I'm probably not going to truly believe them, you know.
Hmm. Do you think experience is the main thing, just sort of observing what they're doing and how they're acting?
Yeah, and we have quite a few people that travel the country using different names, and they use the same story or different names, and they change their names. So if I see someone come in that says they have all these medical problems, and up on their medical record they've never been seen before anywhere, that's a big red flag for me.
Yeah, definitely. All right, well, I think it's the last question in the chat. Student asked, how is the transition between the first 2 years of medical school and the last 2 years?
For me, I think medical school got easier and easier as time went on. The first 2 years is all kind of like, classroom based, book based. I think that's pretty much every medical school. And then your second 2 years is you're going on rotation. So you're almost never back at school. Um, and so I think that, the step up from undergrad to the first year of med school, as far as like studying and how much information you need to actually learn and hold on to is huge. So once you kind of get to that understanding and kind of figure out the way that you learn the best and the way that you can kind of retain information and kind of get your groove as far as like studying and learning, I think the faster you kind of make things easier on yourself. And I think that's a big adjustment for just about everybody. Once you kind of learn that though, I think things just get easier. And then once you get to your third and fourth year, all you're doing is really applying a lot of that information you've learned. So you're applying it, and then you're learning how to kind of use those bits and pieces and raw data to kind of apply to truly seeing patients and helping patients.
Okay, so the first 2 years are more heavy content based, and the last 2 years are more just gaining experience.
Yep. So the first 2 years is pretty much all classes. So you go to classes in med school, and then the second 2 years you go on rotation. So you're shadowing residents and attendings, doctors and hospitals and clinics and things like that.
Okay. And during your rotations, how do the hours work? Is it similar to residency, or is it a lot less hours than that?
Oh, it's quite a few hours less, I would say, in your second 2 years. You're kind of just there to learn and watch and observe. You're not really there to do as much. I would say a good thing about DO schools compared to a lot of bigger allopathic like MD schools is that it's just you and the attending. So I wasn't associated with the residency program, so I would go on all my rotations. It would just be me and the attending. So I was the first assist in surgery. I was doing running the catheters and in vascular cases. I was doing the scopes. I was doing the incisions. I was doing the suturing. I was doing it all. Whereas, like if you go to a big med school and there's tons of residency programs there might be 3 residents ahead of you doing all those things, and you don't really get any firsthand experience. So that's kind of a nice thing about smaller med schools, in my opinion, is that you kind of get a lot more experience, and then when you walk out on day one as a resident, you a lot of times you're kind of better off because you've already been doing those things. Whereas someone that's been in a very large school has been like the fourth in line or fifth in line for a lot of those procedures, things like that.
So you think the smaller med schools kind of help you be more prepared for residency and then also your career?
I don't know about the rest of your career. I think at the beginning of residency, I think it can be helpful.
And then a follow-up question as well, a student asked, what would you say the most important factors are for getting into the residency of your choice?
Um, Looking really good on your rotations at that residency. So you do some rotations in the third and fourth year, and kind of already kind of know what kind of specialty you want to go in. And then you do rotations like a month or two at whatever places you want where you want to apply for residency, and just know your stuff, and get along with everybody. Don't look cocky, and work really hard.
Got it. So do you keep up with attending physicians that you do rotations with as well, or how does that work?
What do you mean?
Do you keep in contact with them, keep in touch with them throughout the rest of your med school as well, or no?
No, not usually. I mean, you can. So like, let's say here at Richland, we have a ton of different residency programs, and we have med students from USC there all the time. And so they'll, one month they'll be on cardiology, one month they'll be on OBGYN, and then they'll be in the ER for a month. And then so they'll walk around. If you get to know them after a while, you'll see them and say hi and things like that. See them throughout the hospital.
Yeah. Well, that's all the questions for me. Thank you so much for your time answering those. If anyone else has any other questions, please feel free to drop it in the chat. But I guess now it's time for you to go over the case study. You want me to present my screen for that? All
Sure.
right. Give me a minute. Can you see my screen?
Yeah, I can see it.
All right, it's all you.
All right, so this is mostly honestly just pictures, some interesting pictures for you guys from me and some of my colleagues that we had just from some random different cases. So go ahead. So emergency medicine is just kind of like a practice based on knowledge and skills to kind of manage the acute presentation of a lot of illnesses. Um, a lot of people kind of call emergency medicine cowboy medicine because a lot of what you're doing is you're making decisions and you're acting on subjective information. I'll have a patient come in, they'll be really sick, they'll have abnormal vital signs and whatever they can tell me, and that's all the information I truly have, and I have to make life changing decisions based on just a small amount of information. So you have to have a good kind of wide range knowledge, and then also be able to kind of move fast and make quick decisions. Okay. So emergency medicine, you just have a lot of different illnesses, presentations, and things that you kind of have to just be aware of and be able to manage. Another cool thing about being in emergency medicine is there's some subset fellowships. So after you finish residency, you can go do some fellowships, meaning kind of get additional training after your 3 years of emergency medicine residency on some other things. So, there's what we have here at Richland is ultrasound. We have global health. We have EMS. I think they call it pre-hospital medicine on here, and we have simulation. So you're kind of learning how to run a simulator and train other people in medicine. A lot of things that we do in emergency medicine are kind of crossover with other specialties. So, we intubate, which means you put a kind of a breathing tube down on someone's throat quite a bit. We're the ones that manage airways for a lot of sick patients. So if there's a cardiac arrest up on a hospital floor and they're in some of the hospitals and they're doing CPR on a patient, we actually go up there and intubate them as the emergency medicine doctor down in the ER. So we'll respond and we'll help them run the code. We'll intubate them, and then we'll let whoever is running the code up on the floor, whatever physician, we'll kind of let them take over after that. And that's something that anesthesiology does. So we'll do that. We do lots of lacerations. We do reductions of dislocations. So I do shoulders, knees, hips, fingers, toes, all sorts of dislocation reductions. We manage strokes, we manage heart attacks, we manage, like vaginal bleeding in pregnancy, OBGYN stuff, and then we see a lot of psychiatry stuff too in the emergency department. So we kind of have wide-ranging skills and experiences in the ER. So here's some things that we've seen. These are some people sent me these pictures for you guys, but like this guy, I think his girlfriend stabbed him in the knee, and that's the X-ray. And then this is a boot that someone actually shot a staple through the side of their boot and went through 2 of their toes. So we had to pull that staple out before we actually got their boot off. We do a lot of toxicology stuff. So this picture on the left, this is Dr. Richardson. He's one of our attendings at Richland. He's also the one that runs the poison center here in South Carolina. And he's a toxicologist. So every year the residency program gets together and we go over to the zoo here in Columbia and we go through all the venomous snakes and we look at them and talk about their different venom and kind of just go through their different characteristics.
So do you see a lot of patients related to toxicology in the ED?
Yeah, we see quite a bit. I would say mostly we see overdoses, intentional versus as well as non-intentional overdoses. But during the summertime, we do see quite a bit of snake bites here in South Carolina, especially copperheads. So this is a trauma of finger injury of some sort here in the middle. That one on the bottom right there is a gunshot wound. That was actually my patient. He was in a shootout with police officers, and then police shot him in the arm, and that was his X-ray. That was a bullet fragments. And then that one on the left is a picture or a video. I don't know if you can play that.
No, I don't think, or I think I've tried. Yeah,
So this is like an airway. So when we're intubating, this is kind of what you see. Those are the vocal cords down there that are opening and closing as someone's breathing, and that's the epiglottis right there. That structure that's kind of sticking out right towards us right there. And so that's where when we intubate somebody, that's kind of where we stick that the tube is down between the vocal cords.
and for that picture of the trauma to the finger, can you talk about what sort of steps you take in the ED and sort of what treatments you give?
Yep. So you can see the fingertips pretty dusky there, so like darkish blue. So the blood flow isn't very good. So on this finger, what I would do is I would kind of wash it out. They get their tetanus, get an X-ray, kind of see what the bone looks like, and then I'd try to suture it, back together, and clean it up, and hopefully the blood flow would somewhat return. I'd splint it and then put them on antibiotics, and then depending on the person, what finger, and a few different variables. I would talk to either orthopedics that night, or I would have them follow up with orthopedics the next morning in their clinic.
So at what point do you sort of refer them to surgery or think about surgery for the finger or any sort of injury like this?
Well, I'd say it depends on the person. So if it's a young kid and it's closer to the hand, so more of a proximal injury, I'd be more likely to consult orthopedics and it's a surgeon earlier. If it's a 80-year-old and he knocked the tip of his finger off, I'm probably just gonna clean it up and suture it up and send him to clinic the next day.
Got it.
So the picture on the left here is a spontaneous bleed. You can see all that kind of white stranding stuff around the right kidney. So that's a CT scan. So this is like a spontaneous hemorrhage from a patient with that was actually on Eliquis, which is the blood thinner. So this is a patient that I had maybe a year ago or so. I had a spontaneous hemorrhage from his kidney. And he's on a blood thinner, so I had to give him blood at the same time as I had to reverse his blood thinning medicine by giving him a different type of medicine. And then the other two is the same patient. The one on the right is a dislocated shoulder. And then when I reduce it, that's the picture in the middle.
Got it. And then can you talk about other treatments you had for the kidney hemorrhage patient? Was it just changing the medications or was there anything else for that as well?
It was, it was resuscitating him. So giving him blood, giving him fluids, and then making sure his vital signs were stable. And then you give a medication called Kcentra, which is like $10,000, and that reverses the effects of the blood thinner.
Okay.
This is a gentleman that has a nail from a nail gun through a couple of his different fingers. Went through the bone in one of them. But something like this, we get it in the emergency department. All the nurses want to come see. Give them a tetanus, you give them antibiotics, and really, I just grab it with the tool and yank it out. Just pull it out of the bone. And then after that, we wash it out as well as we can. A lot of times we'll splint the finger, and then we'll put them on antibiotics and have them follow up with orthopedics. This is a cardiac arrest patient. This one's actually upstairs. So it's kind of a funky picture, but if you see on the left there, this patient has subcutaneous air, so air underneath their skin all over their entire body. This was a COVID patient that had a tracheostomy. I think she's only like 40 something years old. She was in a long-term care unit that was up in the top of the hospital, and she had something to happen. I'm not really sure what, but there was air. Once I got called up for the cardiac arrest, there was air under everything in her body. She had air in her mouth, in her tongue. You see those large structures that kind of come off to the right of that picture on the left there. That's her breast. So she had air even in her breast. She had air in her stomach. She had bilateral pneumothoraxes. You can kind of see in her chest. There's like a darker area at the top corner of each chest, and so each of her lungs had collapsed. So I went up there and then decompressed both of her chests. I took about a 5.5 inch long needle to get down into her chest through all the air underneath her skin. So you can see on the other picture on the right here, those kind of darker areas are gone because her lungs have re-expanded. But all
And so,
that wispy looking stuff is all subcutaneous air.
and so the darker areas right here, this is the air.
Yep. Yep. That's where the lung was collapsed from. So that's essentially like an empty area there. And you can kind of see below that where the darker or the whiter structure is, that's the lung. And then on the next picture, you see how that's kind of gone.
And can you talk a little bit about what causes that air to go into the skin everywhere?
Yeah. So I don't know what started it. My thought is, she had been decompensating up in this unit for probably an hour or two, but she probably had a collapsed lung because back when we had lots of people were extremely sick with COVID, they would get collapsed lungs or pneumothorax pretty easily. So she either had one, and then the air kind of goes through the tissues, and kind of just went all over her body over a couple hours, and either one collapse or she had two collapse simultaneously. I don't know, but over that time, she essentially had pressure that was pushing on her heart and decreased blood return. So she had probably some abnormal physiology that led to cardiac arrest at that point. Once we re-expanded her lungs, we never got her back. She ended up dying.
Okay, well, moving on.
So these are hip replacements. This person's had a hip replacement on both sides. You can see on the right side, she's had a dislocation. So this is something that we commonly do. Some of these people that have these hip replacements have problems with their hips continuously dislocating. So you can see on the right side, it is dislocated. And then on the left side is after it's been relocated or reduced.
So how would you
So in the
relocate?
emergency Yep. So in the emergency department, we sedate these people. So a lot of times we'll have two doctors in the room. One doctor will kind of have them on a bunch of monitors. We'll be monitoring their breathing, and then the other doctor will be doing the reduction. And the one that is doing the sedation will be giving him a medicine like propofol or something along those lines, kind of like the Michael Jackson drug. Um, and then sedating them, and then the other person will be pulling on their leg one way or the other, trying to get their hip joint back in place. In Colombia, we have lots of trains. We have CSX. These are both train accidents. Both of these people had been run over by a train.
Can you talk a little bit about the steps you take to treat this?
um, so, I mean, generally with like a trauma like this, you don't have a ton of bleeding. The blood vessels kind of retract and kind of stop bleeding on their own. But if you have like severe hemorrhage, you put a tourniquet on. These limbs are obviously not salvageable. So what you do is you just stabilize the patient in the trauma bay. Give blood if needed, give fluids. If they're on blood thinners, you reverse those. And then once they're stabilized, you just admit them to the trauma service and the appropriate services such as orthopedics or whatever would be consulted for definitive management, meaning like take them to the operating room and complete the amputation.
And you were mentioning in South Carolina train accidents are a big problem. Can you talk a little bit about how that happened and why they're a big problem here?
We have lots of trains, lots of people that work on trains, lots of train lines. So because of that, it's just a higher rate of injuries. I would say most of the time, or at least half the time, they're actually trained workers. You'll see. So falling off, um, falling in front of, working on them, things like that.
Mm.
This is someone got stabbed in the eye by a pencil. So they're all the same person. And you can see the CT scan there on the right. So something like this, we kind of give them some antibiotics, kind of see what the eye looks like, get a scan, so get imaging, see what structures are injured. Give them pain medicine, obviously, if they need to be lightly sedated to keep them calm, do so, and then you call the ophthalmologist or who whatever specialty is involved with whatever's injured at that point.
Hmm.
Is there more eye infections? One on the left had a really bad ulcer, which was infected, and then the same one on the right. They're different patients, but he has a bad ulcer. You can kind of see the eyes green. So what we do is we use some drops. We numb the eye, and then we use a stain, kind of like we call it. It's called fluorescence. So then you put a stain in their eye, and it helps you kind of see any defects on the surface of the eye. And that thick greenish area, that's kind of like circle-looking area on that eye there, that is all uptake from the fluorescent that shows you the defect.
So what would stabilizing a patient with this sort of condition involve?
So depending on the ulcer and things like that, we would start them on. We'd probably do a culture, so you'd swab the eye, send the cultures to the lab, and then start them on some empiric antibiotics. Depending on if they're wear contact lenses or don't, or what other medical problems they have, allergies, things like that. You'd start them on eye drops, and you'd probably want to get this seen by an ophthalmologist within 24 hours, if not immediately. More eye injuries. So the one on the left is a retinal detachment. This is an ultrasound. When you use ultrasound a lot in the emergency department, you can actually see a retinal detachment. If you see in the back of the eye, there's that V-shaped structure. That's the retina is kind of detached, but that point where it's still attached in the very bottom of the eyeball, you can kind of see there. That is actually the optic nerve. So the retina does not detach there. So that's a pretty bad retinal detachment. And then there's a fish hook in the eye and another severe eye infection, another ulcer. These are traumas, probably MVC. I can't remember what they were exactly, but two open skulls, probably from no helmet. And then that one in the middle there, that's actually an arm that was fractured multiple places. And that guy, I remember him, he actually fell off of a train and got his arm caught in like the ladder or the walkway on the top of the train and then fell off and his arm fractured in multiple places.
Okay, can you just repeat what an MBC is as well?
Yep. Oh, motor vehicle crash. Yeah, so
And
these guys are probably motorcycle crashes.
instead of going off of that again, what would the steps be to stabilize this, or are they? Yeah, how can you
Yeah,
start
so
that?
so when you have a trauma come in, trauma is very cookie cutter. We have like ABCs of trauma, so you just kind of go step by step. You don't go right to the injury at first. You go to airway. So you stabilize the airways. The patient need an airway. Is he able to talk? If he's talking, he doesn't need to be intubated right away. You go to B, breathing. So you listen to the lungs. Does he have lung sounds on both sides? If he doesn't, why doesn't he? Does he need a chest tube? Meaning, does he have a collapsed lung? Do you need to put a tube in to re-expand the chest? C, circulation. You check pulses in all extremities. And so it's very cookie cutter. You go through a long algorithm, and when you find something that's not working, then you fix it. Um, so you don't really jump to count how many bullet holes someone has or where their bullet holes are, because that's not going to save their life. What you're doing is you're stabilizing the patient, you're resuscitating the patient, and then you're figuring out the injuries later.
Okay.
So these guys shot each other. They're cousins. The one in the middle, was shot by the other guy. So the one in the middle um, he was shot first by the other guys with a handgun, and that's a bullet went through his knee. Well, then he hit the ground, and then he shot his cousin in the ankle with a shotgun, and those are his cousin's two ankles there. So they had a bad day.
Okay. And then what is these things are you on the scan? Please.
So you talking about the squiggly things
Yeah.
or the dots? The dots are the BBs from a shotgun,
Oh,
the
okay.
little circles. And then the squiggly lines is bandaging and packing that we have put in the wound to stop the bleeding. These are strokes. These are hemorrhagic strokes. So that you see the white areas within the brain that's bleeding. So these are CT scans of these people's brains that showed hemorrhagic strokes. So
And can you talk?
patients come
Sorry.
in. Yeah, patients come in as like a stroke alert. You identify that they have stroke-like symptoms. They get an immediate head scan, head CT after you initially evaluate them, and this is what you find. So for management, depends on how sick is the patient. Are they obtunded? Do they have an airway? Do you need to intubate them? You manage blood pressure if they're on some type of anticoagulant. You give it the appropriate reversal medicine, and then you would, depending on the stroke or the cause or whatever, then you would consult either neurology or neurosurgery.
And what are the main steps used to identify a stroke patient?
The main, the main what?
The steps to identify a stroke patient. What signs are we looking for?
I mean, you look like what we call focal neurologic deficit. So, do they have like asymmetry or like drooping to one side of their face? Are they not able to use their arm? Are they not able to speak? Do they have slurred speech? Um, are they um, you know not able to kind of see? You can lose like visual fields. Dizziness. We can have a posterior stroke, which is like a small area of the brainstem where you kind of just get dizziness. You don't get any actual call like lateralizing signs. So there's different areas of the brain depending on the type of stroke and the location of the brain. You can have different findings. And this is just dermatology. So like this is a bad rash. This guy in the middle, he had a like a skin cancer that was eating away the top of his head, and those are actually like I think maggots that are in the scalp there, and then just some bad poor foot care. So these are things that we routinely see in the ER. Same thing, more dermatology, probably bad impetigo there on the face. The one on the left is a wound. Does that have a button to play it? The one on the left.
Yeah.
So these are maggots. We actually see maggots on people quite a bit. Then on the right, that's just a necrotic foot, necrotic toes. You see a lot of diabetic wounds. That brown thing in the middle of their foot, that's an exposed bone. And they see a
And what
lot
can
of
you?
poor.
Sorry, go ahead.
We see a lot of people with really poor health care that aren't taken care of. We see things like this, unfortunately, more than we wish.
And then going back to the picture or the video on the left, what usually causes the maggots?
So it's just people that are living in bad conditions, and these are flies are on them. Flies are eating dead tissue. They lay their eggs, the eggs become maggots, and the maggots, that they really eat only dead tissue. They don't eat healthy tissue. So, a lot of times these maggots are actually probably doing somewhat of a good thing because they're cleaning up the dead tissue off these chronic wounds. This was a pneumothorax that I had on the right or on the left. You can see that the lung is collapsed. If you look in the bottom, you can kind of see the area where you can see the border of the lung there. So that was a pneumothorax. And then on the right picture, you can see where I put a chest tube in. So this is called a pigtail catheter. So that I put that tube inside the chest and we hook it up to suction and it re-expands the lung there. A lot of times I'll do these just with some local anesthetic too. They don't need to be sedated, so I'll just put some numbing medicine, some lidocaine right there at your skin. The picture on the left is actually someone's pacemaker. This guy had some really bad skin cancer that actually ate through his chest wall, and his pacemaker fell out. And the one on the right is someone who was working at a restaurant and was really pissed off, and those little um, things people put like receipts through, like pop your receipt through that little metal thing that sits on like a countertop somewhere at a restaurant. This person slammed their hand on it and it went through their hand.
And going back to the picture left, can you talk a little bit more about the steps you take to treat that and go about that?
For which one? For
The
the
picture on the left.
skin cancer?
Yeah, the skin cancer.
So for this guy, I would do is I would give him some antibiotics. I would get some blood work, and I would call and get him admitted. So cardiology would have to remove this pacemaker and figure out how to put a new pacemaker in him.
And
This
so,
pacemaker would be considered infected at this point.
and so this would be something that happens over time, correct? It would just
Yeah, this would have happened over months, if not longer. This person was probably in denial and not following up or telling anybody about what was going on until it actually ate through his skin and the pacemaker fell out.
are there a lot of patients that usually come in a little too late and just wait for things to happen before they come in?
Quite often, yeah, we see that a lot with cancer. Yeah, especially breast cancer.
And why do you think that usually is?
They're scared, they're nervous, poor access to healthcare, maybe no insurance, don't want to tell anybody, live alone at home, things like that.
Yeah.
All right, the one on the left was a head monkey attack. Working at a small ER. This person had a rhesus monkey that tried to. They had the gate open to the cage and it tried to come after her grandchild. So she jumped in front of it and she had cuts and lacerations all over her face and she had part of her skin off her face pulled off. And so she had tendon lacerations in her hand. Um, so she had to go to a hand surgeon. And then the one on the right here has got a really bad infection um, in the back of the throat. There, you see that big black kind of bump right there in the back of the throat. That one had to go to the operating room as well. These are more traumas. So the one on the left had to have their chest open. So if we get like someone with a penetrating trauma, like a gunshot wound or a stab wound to the chest, and let's say they lose pulses or they go into cardiac arrest within like a couple of minutes of coming into the trauma bay, um, then we'll cut their chest open and then try to get to the heart because a lot of times you can find that penetrating wound to the heart and hopefully repair or stick a finger in it and potentially bring that person back. We don't do it for blunt traumas like a car accident, but for penetrating trauma, sometimes we will do that.
So what you usually do for blunt traumas?
You just run it like a cardiac arrest.
Okay.
Yeah, so you just give them blood, you do CPR, you
Mhm.
intubate them. But with a blunt trauma, you have lots of things that are injured that you can't truly fix in a matter of seconds. But if there's a single hole in a ventricle of the heart, you could potentially stick your finger in it, stop that bleeding, and then throw a couple of stitches in it and get it closed and potentially bring that person back. That's kind of the theory, at least.
Okay.
All right, so this one on the left in the X-ray is the same person. That's a mortar from a firework that blew up in his hand. Fireworks are bad. And then on the right there, that's a CT scan of a cervical spine, and you can kind of see where it's been fractured. So that person was, probably at least paralyzed if they survived.
I think that's it. Going back to the fireworks, are the EDs usually really crowded after holidays? Is that usually when you get a spike of patients?
We are. I mean, it depends. I know one of our hospitals here locally, actually, the busiest day we ever had was Christmas Day 2 years ago. Um, Sometimes, the trauma center, so downtown here in Columbia, Richmond's the trauma center, they'll be busy and they'll get some stuff on, New Year's and then 4th of July. Um, but, we get a lot of people that are traveling over the holidays too and kind of being with family. So you'll get an increase in like respiratory illnesses and viral illnesses and things like that around the holidays as well.
All right. I think that's it for the patient cases. There's just three more questions that a few students asked in the chat. One of the questions was, do you owe 1 year for residency as well, or just medical school? I'm assuming this is for the
For the
PV.
scholarship program. Yeah,
Yeah.
for the scholarship program, so it's 1 year for med school, but if you do a longer residency, you can incur some additional debt. Um, so it kind of depends on what track you take. So I only did, four and four, 4 years. So um, that's all I really owed. But some people that do a longer residency program, let's say you do like orthopedics or you do a general surgery or neurosurgery residency, you could incur additional time owed. And then also, if you go, so one of my good friends is a trauma surgeon in the Navy. He did a 5 year general surgery residency that he would then practice as a general surgeon in the Navy for 2 years. And then he went and did a 2 year trauma critical care fellowship. So then he owed another 2 years on top of what he already had. So I think when all is said and done, he'll be at like 14 years when he no longer owes the Navy any more time.
Okay. And the next question is the gruesomeness of the emergency department cases something you get used to over time, or is this something you can sort of decide for yourself during your medical school, the
I think
rotations?
you decide. Yeah, I think that's something that you have to decide that early on. I would say if you don't like the blood, you don't like the trauma, emergency medicine may not be what you're meant for. Because I see blood every single day. I see injuries every single day. I'm suturing up injuries every single day. So everyone kind of gets to know what they really want to do. I would say in medical school, a lot of almost all my friends that wanted to do a certain specialty when they started medical school, most of them ended up changing. So I wanted to do surgery earlier on, and then I just figured the lifestyle wasn't necessarily for me. So you kind of learn and change things because you're going to be getting experiences that you've never had before. So you kind of things change. I'll say that.
Do you think it's gotten easier for you to deal with cases as you sort of progress throughout your career?
Um, yeah, I think I've learned to compartmentalize a lot more than
Yeah.
when I first started. Yeah.
And then the last question was, would an MRI identify as a stroke better than a CT scan would?
Yes. So CT scans will show a hemorrhagic stroke, so a bleeding stroke right away. But ischemic stroke, so lack of blood supply, like a clogged artery, you will not see that immediately on a CT scan unless it's extremely large. So MRIs will show a stroke immediately and an ischemic stroke, but a CT scan not necessarily.
And sort of going off of that, could you generally describe the differences between an MRI and CT scan as well, and sort of what you use each one for?
Yep, CT scan's a lot cheaper and a lot faster. CT scanner is a lot of hospitals will have several CT scanners. I can CT scan someone's head in like 3 minutes. To do an MRI of someone's brain without contrast can take 20, 30 minutes. And MRIs will have scheduled patients throughout the night. So if one hospital has one MRI machine, they probably have patients coming in outpatients coming in at 2 o'clock in the morning for an MRI of their knee that they've previously scheduled. So it's harder to get an MRI, and you have to have a really good reason in the emergency department to get an MRI on an emergent patient. Generally, the only reasons why we'll get an MRI in the ER is for if we're considering for a stroke or a spinal cord impingement for some reason. Any other reasons for MRI, most of the time they need to do it as an outpatient or as an admitted patient.
The CTs are definitely a lot more common.
Yeah, a lot more common, a lot faster, and then a lot more easier to get a patient into.
All right, well, I think that's all the questions I have, and also the chat has as well. Thank you again so much for your time, this evening joining us, and then thank you to everyone, all the students as well for joining us this evening.
Mm.